Thank you for tuning in for another episode of the top 5 things you need to know from the American Urologic Association meeting. My name is Max Cates. I'm director of the Division of Urologic Oncology here at the Brady Urological Institute at Johns Hopkins. And today I'm joined by Dr. Sunil Patel, who leads our testis cancer program and is going to be telling us the top 5 things you need to know about testis and penile cancer from the AUA meeting. So Sunil, take it away.
Thank you, Max, for the kind introduction. And yeah, we had a great and productive AUA this past couple of weeks ago in San Antonio. And the big 5 things to really kind of take home about penile and testis cancers. One is really the new role for primary RPLNDs, especially in early stage seminomas. 2 is the potential role for PET scans in early stage seminomas. 3 is really looking at 3 and 4, I guess, are really looking at surgical technique, the adoption of extraperitoneal lymph node dissections and the outcomes associated with it, and then really bringing in the role for robotics in retroperitoneal lymph node dissections in testis cancer. And then finally shifting it over to penile cancer, always kind of looking at the newer surgical techniques and innovations, especially in the inguinal lymph node dissections.
All right, that's fantastic. So let's work through that. So the number one thing you need to know about testis cancer from the AUA meeting is that primary RPLND may have a role for early stage seminoma. And that strikes me as kind of changing all of the board's questions we always studied, all of the dogma held that for seminoma, you start with chemotherapy, but now it sounds like there's an increasing role for surgery. Can you tell me why that is and what that's based off of?
Yeah, so great question, Dr. Cates. So yeah, you are right. That's really changed the dogma, and I think we're learning more and more about testis cancer as kind of the years have progressed. Conventionally, chemotherapy has always been a standard of care, and rightfully so. It's very effective. However, over the years, we've really learned that chemotherapy, even though very effective, is associated with some toxicities. And so therefore, there's a large clinical trial called the SEMS trial, which Hopkins was a part of, really led by a big pioneer in testis cancer, Dr. Sia Daneshman from USC, and a multi-center, multi-institute clinical trial was performed called the Surgery in Early Metastatic Seminoma, really focused on stage 1, stage 2 pure seminomas, limited to the retroperitoneum lymph nodes to 1 to 3 centimeters. And we really looked at the role for surgery in that setting over chemotherapy. And 55 patients were enrolled in this study, and we really looked at the recurrence-free rate survival. And the first recurrence-free survival was 81% at 2 years. With roughly around a 22% recurrence rate. And about 16% of those patients had clinically node or pathologically node negative disease. However, we were finding that patients were doing very well with these surgeries. We're clearing out the retroperitoneum, and we were potentially saving them the toxicities associated with chemotherapy. So that, given the results of this trial, actually has switched the dogma and actually changed practice and guidelines, which has now been recently adopted in the 2024 AUA new iteration of management of testis cancer. So it's a really big kind of change in the guidelines, which is, again, the big takeaway from the AUA and the new guidelines.
That's excellent. So, as we think about management of seminoma, your second thing that we need to know from the AUA and testis cancer is that there's really maybe a role for PET imaging for early stage disease, not just after chemotherapy. Once again, all of our board's questions that we're thinking about said, when do you get a PET scan for testicular cancer? And the answer was after chemotherapy with a certain size criteria, and we all memorized that. And now you're telling us from the AUA that also is being sort of challenged. Can you tell us a little bit more about that?
Yeah, so great. So kind of great point. So there was only really one role for a PET scan in testis cancer, and that was a patient who had a pure seminoma who underwent chemotherapy and had residual disease either in their lungs or in the retroperitoneum greater than 3 centimeters. More often not, patients we attributed to having fibrosis because the chemotherapy worked so well. And so that's why there was the limited role for the PET scan. However, looking at the SEMS trial, this was almost like an adjunct study to it. Brian Hu looked at this while undergoing this study, the SEMS trial, they actually looked at a small cohort of these patients. And so of the 55 patients that enrolled in the SEMS trial, 26 patients of that trial, so roughly 47%, actually had a PET scan performed prior to surgery, so ranging from 1 to 90 days prior to surgery. If you look at the PET scans, about 77% of them were positive. So that was 20 out of the 26 patients. 18 of those patients had pathologically positive lymph nodes. So that's a positive predictive value of 90%. And so we're talking about patients who haven't undergone chemotherapy, who have nodes less than 3 centimeters, because that was the inclusion criteria prior. So now you're looking at a group of positive predictive value of 90% is pretty good. And so if you look at that number correlating to the patients who had pathologic node negative disease based on the RPLND, which is about 16%, you may be able to potentially see a lymph node. Is it reactive? Is it not reactive? And classically with seminomas, only 50% secrete tumor markers. And so those patients who don't have elevated tumor markers, you're left with this kind of 1 centimeter lymph node. You're like, do we want to do a surgery? Do we not? In a pure seminoma, we may have an additional tool, right? I'm not saying that this is a definitive change in practice, but the data that they present is actually pretty remarkable. I think a positive predictive value of 90% is pretty good. Again, 26 patients are quite low, so I think we need to extrapolate that and see if we can enlarge that. But I think this is potentially may add another option in our tool belt to have and add more information prior to undergoing surgery. So I think this is a kind of a really important study that they presented.
That's excellent. Thinking about the management of testis and penile cancer, your last three things that we need to know are all in the surgical realm, and I think that makes a lot of sense, because what you just told us is that we're increasingly doing surgery for early stage seminoma. We're using novel imaging and potentially, we didn't talk about this, but eventually circulating tumor biomarkers to help us understand whether surgery may be preferential to observation or chemotherapy. So the role of surgery in this disease space is only increasing. And so it behooves us to improve our surgeries. And so let's start with the third thing you need to know about testis cancer from the AUA, which is the expanding role of extraperitoneal RPLND. Can you kind of describe to those that maybe it's been since their residency training when they last did an RPLND, exactly what that entails and why that may be better?
Yeah, so classically, as we all learned, the retroperitoneal lymph node dissection, the goal of the surgery is to clear out the retroperitoneum, and that's usually done through a pretty big incision, classically taught from the xiphoid all the way to the pubic bone, and intra-abdominal approach where you're mobilizing all the intestines and kind of moving them out of the way to access the retroperitoneum. Again, a trailblazer in this area, Dr. Siva Dineshwan, has kind of pioneered this really interesting technique, which is maintaining the peritoneum or the intestines in the peritoneal sac and mobilizing it so you can access the retroperitoneum without entering the peritoneal cavity, which has been all very kind of known and proven to decrease intestinal complications such as ileus, bowel injuries, etc. And so we've kind of shifted a little bit towards that. And then this kind of ties into, I guess, the next big point we're going to talk about, Dr. Cates, about the robotic and open. But the extraperitoneal essentially technique utilizes that peritoneal sac and maintains it to decrease the morbidity associated with the retroperitoneal lymph node dissection while still being able to complete the surgery in a full complete technique. Bilateral template, as we kind of remember, there's different templates that we use in retroperitoneal lymph node dissections, but this technique still allows you to do both, but maintain the peritoneal sac leading to less ileus, less morbidity, and early discharge, which obviously decreases a lot of complications and issues, which we can dive into more. But that's really the fundamentals of an extraperitoneal lymph node dissection, and it's been published recently through USC, and we're actually combining their data now since we're doing a lot. Specifically, I'm doing a lot more of those here. We're going to combine that to show that that's actually possible to be done at different institutions and still have the similar outcomes.
Yeah, I'm really excited to see your series published in this, and I think it's an area of phenomenal progress. So the fourth thing that we need to know is the controversial role of robotic surgery for testicular cancer is only continuing. Can you tell us a little bit about how that was brought up at the AUA and what the controversies are?
Yeah, so historically it was very controversial. Again, I think based on our guidelines from the AUA guidelines historically in the several years past, it was kind of fraught upon. There was no role for robotics, whether lymph node counts and yields were going to be sufficient, whether we were going to clear the retroperitoneum sufficiently. I think that dogma has kind of changed, and there's more and more evolving role for robotics and retroperitoneal lymph node dissections. And we've through several studies published this year and discussed at the AUA, there's a big systematic review, and they looked at 15 years of robotic RPLD compared to open and robotic. And essentially what they found was that there was a low conversion rate from robotic to open, to roughly 2.2 to 9%. So not that high, 9% usually in the post-chemotherapy setting and 2.2 in the primary. But the biggest thing they found was that the average length of stay for robotic retroperitoneal lymph node dissection was only 2 days compared to 4 to 6 in the standard open. Again, and we've actually, our institute here, with a couple of our residents, we've actually looked at the cost outcomes associated with that. And you see that actually the robotic tends to be cheaper when you're looking at the conventional open approach with the 4 to 6. That whole dogma gets switched out with extraperitoneal, which I'll talk about in a second. But if you're going back to the systematic review, which they presented, the oncological outcomes were pretty similar, and with only disease recurrence rate of only about 6.7%. So their data shows a little bit better numbers than the open kind of contemporary series. But these are all in expert hands, and that's the one thing to take away is retroperitoneal lymph node dissections. Again, there are not that many of us that do high volume of them, let alone high volume robotic retroperitoneal lymph node dissection. So there's always a caveat. I think experienced robotic surgeons who feel very comfortable with the procedure itself and the robotic application, yeah, I think there's a role for that, especially in the primary setting. So it's been shown to oncologically be sound. Decreased length of stay, decreased blood loss as well, and still provide the ability to do a good nerve spare. However, now getting to that last tidbit, the whole discussion about open versus robotic and the length of stay, I think that's where we may have to challenge that, because with the extraperitoneal approach, where our average length of stay is only 1 to 2 days. And so that's going to rival that, with blood loss being very similar, and morbidity associated with the extraperitoneal approach being very similar to robotic. So I think now, if you're now going to time that last bit, the cost utilization, which has been a topic of interest throughout this several years, not just for testis cancer, but for other applications, it's going to start rivaling the robotic approach, because if we're able to meet that length of stay, same blood loss, and not have to use a robot, then I think we may have maybe a really difficult decision in terms of open extraperitoneal versus robotic. But however, at least now we know there is an emerging role for robotics in retroperitoneal lymph node dissection.
That's very well said. So let's for our fifth and final thing that you need to know, let's switch to penile cancer, which, as we all know, is a rare cancer. Yet, many urologists throughout the country will see 1 or 2 cases a year. And once again, it's highly tested, something we all need to be familiar with. And the dogma that we've all kind of learned is these inguinal lymph node dissections are crucial in staging certain types of penile cancer, but they're fraught with complications and with with a lot of issues. So do you want to talk to us about that?
Yeah, so great segue. So again, yes, you're 100% right. Penile cancer, very rare, especially in the US. We don't see that many cases. Certain areas of the world do, or excuse me, in the US do see higher numbers. However, again, very rare disease. About a quarter of the patients that present with penile cancer would will have some sort of inguinal lymphadenopathy, and much lower numbers will have inguinal plus pelvic lymphadenopathy. And if you look at it, and you're going back, diving into kind of the staging and grading of penile cancer, we do have a good cutoff in patients who have PT1B or greater, so lymphovascular evasion or greater. Usually those patients we recommend groin dissection if they're non-palpable or non-bulky. If they're bulky, these patients should get chemotherapy and radiation. So if you look at that, though, a lot of patients aren't getting bilateral inguinal groin dissections. And the reason why, and if you look at it, the rate was only about 27% of those who actually had enlarged lymph nodes. The vast majority are getting chemotherapy and radiation. And the reason why is classically, we were always taught there are a lot of complications with a groin dissection, right? The tissue necrosis, the lymphedema, potentially pain, the bleeding, the patients needing drains, compression stockings, all of these things. And I think over the last 15, 20 years, we've understand there used to be a radical inguinal groin dissection, that was when we potentially had to use muscle flaps, and saw a lot of higher rates of tissue necrosis. The modified inguinal groin dissection has definitely changed that and decreased a lot of that lymphedema, decreased the tissue necrosis and the need for flaps. And that's really focusing on the fossa ovalis. At the AUA this year, Dr. Raj Masters really highlighted now urology has had a big impact in the field of robotics. And now we're seeing more and more of that kind of shift even to the groin dissection, which is really fascinating. So what we're seeing is that given those concerns of lymphedema, visualization, protecting those veins, but clipping those lymphatic channels, as well as the rates of tissue necrosis and skin flaps, is there a role for robotics? And I think over the past couple of years, as we've all become better robotic surgeons, I think there is a role, and Dr. Raj Masters presented some good data on that. And if you look at the data, so the first robotic inguinal groin dissection performed by urologists was roughly in 2009. And if you looked at the major complications in open surgery, was about 21%. Robotics have decreased that by based on his data, this is a retrospective analysis, by 89%. And what I mean by that are lymphoceles, lymphedema, surgical site infections, and as well as tissue necrosis. The rates of skin edge necrosis was less than 2% in the robotic arm, which is significantly lower than 15% in the open. If you look at the median lymph node obtained by open and robotic, they're equally similar, so 12 to 15 nodes per site. Local recurrence rate were about 7% and the 5-year progression-free survival was about 7 to 74%. And the overall survival rate was 67 to 73%, which is very similar from robotic and open. So if you look at that, if you're looking at comparable oncological outcomes and decreased complications, which is pretty dramatic, lymphedema, tissue necrosis, yeah, you're looking, even then, again, this is a retrospective analysis. Again, like we've discussed this numerous times, even with cystectomies as well. There is a role for, I think, a clinical trial comparing open to robotic in a prospective manner. However, with retrospective data looking at this, there's pretty good argument saying if you're facile with a robotic system, a robotic inguinal lymph node dissection may be superior. Not saying it's in certain hands compared to open. So it looks like there's potentially a new emerging role, at least in the oncologic field of penile cancer, which would be really fascinating to see the next steps, potentially prospective clinical trial. But I think the data that we're presenting and seeing, and hopefully numbers increase, we can potentially see a change in that dogma as well.
That's really fantastic. Thank you for sharing with us. This has been just a wonderful discussion. Once again, I want to thank Dr. Patel, and please stay tuned for future episodes of the 5 Things You Need to Know from the AUA in other disease spaces.